Well, good morning or afternoon, depending on what part of the country that you're from today, and welcome to the Facility Compliance Think Tank presented by Soleran. My name is Mike Foley. I'm the Vice President of Strategy and Business Development here at Soleran and the moderator for today's call. This is our first webinar in our spring three-part series. Today's topic is a great one. It's current and future building designs due to COVID. Our webinars really do have two purposes. One is to discuss best practices in the areas of facilities, life safety, emergency preparedness, security, and other compliance-related topics. But the other, and point of the webinars, is these were created to help healthcare professionals network together, share best practices, and share ideas. With that said, let's introduce our panelists for today's webinar. Let's start with Lance Woolf. Lance is the Director of Life Safety Compliance here at Soleran. He's a former Life Safety Code Surveyor for the Joint Commission. He has a lot of experience in hospitals. He spent 17 years at the Director and Senior Director level in hospitals. And during that time, he oversaw engineering, emergency preparedness, safety, biomed security, and environmental services. Next, we have Chris Tokas. He's a Deputy Director for the Facilities Development Division at HCAI OSHPD. He's a Chief Building Official for all California hospitals and skilled nursing facilities. He has over 38 years of experience in structural engineering design. He's authored and co-authored several papers related to earthquake-resistant designs of structures. And he also teaches seminars for professional organizations and courses related to earthquake-resistant design structures for the University of California, Davis, but also California State University in Sacramento. And finally, Vic Mosby. He's an architect at ACI Boland Architects. He is the CEO and president and principal at ACI Boland Architects. He has over 30 years experience in healthcare facility design, and he's been involved in all phases of design and construction administration. He's managed hundreds of healthcare projects as well, and he received his bachelor's degree in architecture from the University of Kansas. I appreciate all of our speakers taking time out of their busy days to provide us with their knowledge and expertise on this really important topic. This should be a great hour and be very informative for everyone here. Before we get started, just a couple of housekeeping items. Really the flow of the webinar, each panelist will have 10 to 15 minutes utilizing PowerPoint slides to discuss the topic. We encourage you to do a couple of things. One, take screenshots for any of the data that you would like to see and save that for your reference, but feel free to use the webinar itself as a reference and share that with folks in your hospital or folks in the community as well. So after our speakers have presented, we'll have roughly 10 minutes for a live Q&A session. So please use the Q&A button at the bottom of your screen to ask your questions. If the toolbar disappears, just scroll your mouse over it and it should reappear. On one of the last slides of the presentation, we will have FCTT's web address on it, so you can utilize the site to help you network in the future, as well as get in touch with Soleran after the presentation. With that said, let's get started on the webinar. Chris will kick it off by giving you an update on the effect of the pandemic on future hospital design and construction. Chris, take it away.
Thank you, Mike. It's a pleasure to be here with you. I want to thank Soleran for inviting us to be part of this panel. This panel actually, it is coordinated in such a way that the information that you're going to hear today, is going to be extremely helpful as we move forward in the new designs that we're going to see in the arena of healthcare. As COVID-19 cases filled emergency rooms and intensive care rooms across the United States, based on lessons learned in the last 2+ years, many physicians, healthcare consultants, hospital design professionals came together. And they started talking about how the modern hospital design should change to avoid the repeat of lessons learned, during this national crisis. As discussions started fueling up, there was one topic that came forward again and again and again. There was one clear lesson. Modern hospitals lack the flexibility to accommodate the much needed surge capacity that we have to have, I guess, so for situations as the one that we basically are facing, I guess, so, and hopefully, I guess, so we're over it. Many hospitals experience extreme shortage of space, shortage of resources to treat COVID patients, and also, I guess, so handle again non-COVID patients, I guess, so with all kinds of again modalities, and also, I guess, so at the same time protect, I guess, so the most valuable resource that we have in hospital facilities, the hospital personnel, so caregivers and so on. Now, over the years in hospital designs, we thought that we were preparing for resilience. However, it has been proven, I guess, again, these 2+ years, that we were not prepared for it. In this highly networked environment that we live, we have found that a system-wide view is essential so that we can plan, I guess, for much needed resiliency. The healthcare design community has taken a closer look of what basically, I guess, so again, a resilient environment in the healthcare industry, I guess, so needs to be formulated, and then what individual facilities, I guess, will need to step up for, and it comes down to one concept: flexibility, viable flexibility. You see, flexibility and agility are essential components of resilience, but again, quite often they have been value engineered out of systems optimized for efficiency and, of course, minimizing costs. If we are to be better prepared for the future, we may need to reconsider our notions of value and the potential consequences of leaving so little room for agility. As we speak, hospital designers plan to design future hospitals that they are more flexible in order to accommodate pandemics or other, events, I guess, so that will require, I guess, so for us, I guess, so to basically surge up and create, I guess, so again, I guess, so the temporary environment that we need in order to address, I guess, so surges, which, as we have seen in the last decade, I guess, so, or so, even longer than that, it occurs every 5 to 10 years. Next slide, please. I have quite a few slides. Again, I guess, so for your benefits, I'm going to limit, I guess, my discussion, I guess, so the time frame that I have, I guess, so, but you're more than welcome, I guess, so to all the slides that I have, I guess, so because there are a lot of lessons that we basically bring forward to the community as we are gearing ourselves for new designs to accommodate, as I said, this resilient environment that's much needed. Well, let's take a look at the operational changes that COVID forced on the health delivery system. Number one, what is the goal of healthcare facility? To be able to isolate and treat infectious patients while continuing to provide other vital services that keep people healthy and bring in the revenue. Well, okay, so as such then, okay, so the main objectives are, number one, to be able to triage and check in patients remotely. Number two, quarantine infected in separate facilities and reduce physical contact with caregivers. And number three, deal with resurgences. So in this case, coronavirus, okay, so in other cases, I guess, so we saw Ebola. We have seen all kinds, I guess, again, of diseases, I guess, so that's spreading very, very quickly. Next slide. So here are some lessons, I guess, so that basically, I guess, so force us to take a look of hospital designs. They need to be redesigned. They need to have, I guess, a completely different way of approaching, I guess, so healthcare. As a first step, hospitals had to quickly make patient intake safer. So they had to separate infectious patients. So as such, then it brought an end to the traditional single entrance. So implement restrictions of patient visual traffic flow to control cross-contamination. So again, in the beginning of the pandemic, I guess, so that was done, I guess, so via tents, I guess, so proved to be totally ineffective, especially, I guess, so for the duration that were utilized, I guess, on weather setting. And again, I guess, so from the tents, I guess, so we moved, I guess, so into a more what I would call, I guess, so stable space, I guess, so, and you can see some of the pictures there. Then a lot of hospitals, I guess, so brought in what we call, I guess, so again, digital check-in of patients, so that we can avoid, I guess, so bringing highly infectious patients to the facility without the proper means and methods. So as the COVID numbers began to rise, medical facilities started limiting, I guess, as I said a minute ago, the entry. So entry portals, Okay, so also, okay, so in this case, as they were set up, okay, so they found all kinds of other opportunities. Okay, so for example, not only just screening, okay, so patients, okay, so but also, okay, so collecting patient information, okay, so conducting rapid testing, all those lessons, okay, so have been taken, okay, so and are positioning new designs to accommodate that, okay, so literally in a matter of minutes. So long-term considerations include providing storage for supplies like PPE, okay, so and wheelchairs, again, hand washing stations near the entry, okay, so creating negative pressure capabilities, providing space for new technologies, and so on. So everything has been rethought of creating a robust environment so that we can accommodate, okay, so again, stepping up or surging up, if you will, okay, so for again, unfortunate situations that might arise in the future. Next slide. So the next, again, area of the hospital that proved to be totally inadequate, it was emergency departments. So here are some observations, okay, so that we basically, I guess, saw, I guess, in today's environment. Emergency departments basically, okay, so they are not compartmentalized. Okay, so we found all kinds of issues there. So they need dedicated isolation and decontamination rooms for patients. Okay, so now in the COVID situations, okay, so highly infectious patients. However, okay, so in the environment that we live today, and we have all kinds of behavioral issues, again, okay, so EDs require specific spaces to treat, okay, so patients with behavioral health, other situations, okay, so where we have chemical contamination and so on. So the lesson here is basically, okay, so ED departments, okay, have to be designed, okay, so with a fundamental concept to be compartmentalized. Compartmentalized in multiple zones so they can be effective in caring, okay, so for different groups of patients. So when designing new facilities, features such as, again, okay, so what just I enumerated earlier, okay, so are going to be brought forward so that we do have the capabilities in order to surge up, okay, so during crisis. Next slide. So the other issue that hospitals were confronted with, it was capacity. And so again, in the beginning, okay, so hospitals thought, okay, so that we can surge up by basically bringing forward alternate care sites. Well, that did prove totally ineffective. In order to staff up alternate care surge sites, you need more staff, you need more equipment, you need more resources, and so on. So hospital administrators very quickly, okay, so realized that I gotta provide, again, the level of care needed through the hospital proper. So as a first step, okay, so normal operations, regular patient treatment, elective procedures came to a full stop. So the number of beds, okay, so that they needed, okay, so in this case, okay, so it was provided through the hospital proper. They doubled and tripled, okay, so the number of beds, okay, so within the hospital proper. In some cases, they use shell spaces, again, but in most cases, okay, so you saw a typical, again, patient room, okay, so rather than having a single occupancy, okay, so it was converted to double and triple. That's where the medical gases were. That's where the resources were, and so on, okay, so. So in the future, okay, so then such patient rooms are going to be designed, okay, so with that in mind, okay, so how can I surge up? What systems do I need to have, okay, so in this case, in place in order to make, again, okay, so a situation, okay, so that I'm facing, okay, so to be able to resist, okay, so what's happening and provide the number of beds that I need. Next slide. So another issue, okay, so that basically we faced, okay, so in this case is what we call, again, hot zones versus, again, safe zones and so on, okay, so. The pandemic brought on the surface that it is extremely important to delineate safe zones and hot zones in a hospital, meaning that healthcare workers need areas so that they're able to operate with less PPE and be able to, again, okay, so not be contaminated, not come in contact, okay, so with highly infectious patients. So in order to do that, in order to basically have a safe zone to be effective, the medical staff need to easily identify, okay, so again, where they are at, okay, so the level of safety, okay, so that each zone has. So future designs, okay, so are basically going to incorporate color-coded doors, embedded LED lighting that change color to represent different conditions, the uses of different colors in flooring materials, and so on, okay, so all that will give the capabilities, okay, to the medical personnel to understand, okay, so in this case, okay, so how to literally provide the services to a hospital from, okay, so again, highly infectious areas to safer areas. Next slide. So another area that proved extremely deficient, it was the number of intensive care units. So this disease, okay, so it's highly infectious, okay, so via, okay, so the number of quanta, okay, so that they are basically are scaled, okay, so from a highly infectious patient. So in that case, okay, so you do need, okay, so the proper ventilation requirement, okay, so in a hospital environment. So you need negative pressure isolation. In order to do that, okay, so it's not that you can just take a room, okay, so and basically, okay, so add fans and ducting, okay, so and everything else, okay, so it needs to be properly ventilated, okay, so we saw situations that, again, dangerous conditions were developed because the ventilation was not in the outside, it was in the lobbies and so on. And the other thing that you need, okay, so in this case is anterooms. So future designs, okay, so are going to steer away, okay, so from the customary one ICU per 35 bed per 35 patients, okay, so they're going to go to a higher ratio, okay, so and then, okay, so also, okay, so the mechanical unit is going to change in order to accommodate, okay, so for surging up. Next slide. So again, who is going to be, I guess, the system, I guess, so that is going to provide us that capability? Well, today, I'm happy to tell you, I guess, so that our BMS system, I guess, so basically give us the automation for us, I guess, so to make those changes, I guess, so from one minute to the next. So to change patient units for higher acuity. So that way, okay, so in this case, okay, so we can actually, okay, so formulate our BMS system, specifically the mechanical system with all the automation, so that I can actually change those environments and provide the appropriate healthcare that I need, okay, so by basically, okay, so rethinking, okay, so the circulation in triage, ED units within the hospital proper and so on, okay, so that I can protect the patients. Next slide. HVAC systems. As I said earlier, they're not just, okay, so for ventilation. HVAC system basically are the lungs of the facility. So they provide, okay, so the environment for us, okay, so to, number one, treat patients safely. Number two, okay, so reduce contamination. Number three, okay, so reduce infection and so on. HVAC systems in a medical facility play an extremely important role in stopping and destroying the virus from spreading, okay, so through the hospital, because many diseases, okay, so spread through the air. Okay, so as you can see there, okay, so there's a lot of changes that are going to take place, and there's a list of items in the HVAC system, starting, okay, so from, again, okay, so UV treatment coils, okay, so to changing the relative humidity, okay, so enhancing filtration and so on, okay, so there's all these items that are going to basically be incorporated, okay, so in new design. So looking ahead, okay, so the, again, the BMS system or your building management system, okay, so will consider pressure monitors for all areas that require pressure compartmentalization. Okay, so designing air handling units for emergency department areas to handle 100% of the pandemic operation, implementing purge mode, okay, so that will allow the entire ED to be exhausted, and validation of directional airflow systems and so on. So the automation, okay, so and okay, so the controls that are going to be included in the HVAC system, okay, so is enormous. And again, like I said, already has started. Okay, so we already are changing our building standards in order to accommodate those changes. Next slide. Another area of concern, okay, so during the pandemic, it was the medical gas system. As it was proven, the medical gas system basically, okay, so have been under design. So again, future designs, they're going to increase medical gases, suction electrical power capability deployed quickly to handle space needs in a massive patient surge. Another area that needs to be revisited is the diversity factors, piping, sizing impact. A lot of the facilities are wanting to increase the pressure, but they couldn't. So all that comes, okay, so in, again, in the proscenium, okay, so as mechanical engineers are taking a closer look, okay, so in order to basically design robust hospital buildings so that we can accommodate, okay, so surging up. Next slide. Now, in order for a hospital basically to have the ability to know who and what staff came in contact, that basically, okay, so reduces the risk for infectious diseases getting out of control, okay, so is a lot of things, okay, so that basically, okay, so transpire because of movement of equipment, movement of patients, movement of staff, knowing where everybody is, knowing whoever came in contact with who, and so on. So this is not new. RFID is not new, but it's been utilized, okay, so in new ways. RFID basically allows staff, okay, so to know exact location and condition of critical resources needed. So if equipment, okay, so are basically tagged with RFID, okay, so transmitters. So then, okay, we can track the assets, okay, so by room, by floor, okay, so and so on, and thereby, okay, so in this case, knowing exactly, okay, so how to allocate resources within the hospital building, and thereby reduce, again, the transmission of pathogens, okay, so throughout the facility. So, next slide. More automation as far as controlling infection control systems. There is a list of items here. Okay, so one of the more fundamental things is basically, again, hand washing. Hand washing, okay, so plays paramount importance in the hospital environment. The number one offender are doctors. They don't wash their hands, okay, so the way that they should. So thereby, okay, so in this case, there are automated systems, okay, so that basically, okay, so the doctors monitor their moves throughout the whole facility, okay, so with proper alarms, telling them, okay, so that they need to wash their hands, and thereby, okay, so before they enter the room, okay, so in this case, okay, so reduce the probability of, again, bringing pathogens into that room. Other automations, okay, so that's as operational components, that's as water found, this list of items, okay, so that it's enumerated here in the slide, okay, so that can reduce, okay, so transmission of pathogens. Simple things as disinfectant mats at the entries, okay, so again, okay, so don't bring, okay, so literally, okay, so pathogens within the facility and so on, okay, so next slide. My apologies for going this fast, okay, so but there's a lot of material here, and I want to give you a general idea of where the industry is going and what automation basically is brought, okay, so into our facilities and what the thought processes are, okay, so that we can basically create an environment that's robust, okay, so to accommodate future, again, outbreaks. Another innovation, if you will, okay, so that was brought forward, we need to keep doctors and patients at a distance. And there are multiple techniques that can be utilized in this case. So I'm not going to go, okay, so in depth, okay, so, but that's an idea that came really the first couple of months of the pandemic, and right now it's been taken into a new level by incorporating a lot of cameras, okay, so that we can actually protect, okay, so the most valuable resource that we have in hospitals, the healthcare, again, workers that we have. Next slide. You can see in this upcoming slide, okay, so that a lot of automation is happening. So there's nothing new there, but it's brought to a different level. Computerized robots, okay, so again, mechanized helper, as often enough, okay, so they're called to provide more services into, again, hospital wards, okay, so thereby, okay, so protecting, okay, so our doctors and nurses. Next slide. Telehealth. Okay, so I don't know if I brought, okay, so that, okay, so in the beginning of our presentation, but during the pandemic, okay, so telemedicine became more widespread. Telemedicine, okay, so prevents exposure, as simple as that. So today, okay, we have technologies. The technology will become the catalyst. So that for us, okay, so to be able, okay, so to deliver, again, uninterrupted telehealth. So long-term strategies are considering a center where telemedicine can be coordinated next to the hospital proper, such as centers where basically include dedicated telemedicine rooms with acoustic privacy, okay, so good speech clarity, adequate lighting, and so on. So combination of the data that we gather, so and then artificial intelligence will make a society more resilient to disease spread. Plus, okay, so in this case, okay, so again, okay, so we can quadruple, okay, so the way that we reach patient, okay, so via telemedicine. Next slide. So here are some stats, okay, so that we had, okay, so near the beginning of the pandemic, nothing has changed, okay, so if you take a look at the same stats today, they're going to remain the same. So the industry is looking for, again, accommodating, again, healthcare, okay, so through telehealth. The industry is looking, okay, so basically to deal, okay, so with new designs that bring on the table, okay, so whatever it needs in order to surge up and so on, okay, so you have, okay, so the stats, okay, so, but again, the percentage might change a little bit, okay, so, but the breakdown is the same. Next slide. What we are doing in our organization, okay, so we are putting together and emergency guide. Okay, so we have the emergency design task force and the emergency guide. Okay, so basically it's going to accommodate, okay, so needs as far as future designs. Basically, okay, so we'll discuss 6 priorities. I'm not going to go through it. Okay, so you can download it from our webpage. So that way, okay, so as hospital designs move forward, okay, so it would be good, okay, so in order to incorporate, okay, so again, those new ideas, new thoughts, okay, so into the designs. The problem that we have today, building standards move very slow. So we here at HCI, okay, so are, or as we, again, formerly known as OSHPAD, okay, so my job is to provide, okay, so the best possible environment for our people, for our citizens to enjoy the best healthcare possible. So thereby, okay, so I can't wait for building standards to catch up. I have to move forward and I have to put in the proscenium whatever it takes so that I can provide to our people, okay, so the best possible resources for healthcare. Next slide. Next slide shows you, okay, so in this case, okay, some of, again, okay, so the resources that we're bringing forward. So I'm not going to belabor, okay, so the issue, okay, so you can always download it from our website, okay, so you can see the direction that we're going. Next slide. What in the next couple minutes, okay, so, and I don't want to basically spend a lot of time on this one, I guess, because we have a lot of important material after me, is I want to basically discuss very quickly the changes that are happening on the design and construction side, okay, so during the construction of the building. So next slide. Things are changing. So this is not news. It's basically digitization. It will become, okay, so again, okay, so of paramount importance of basically, again, assisting, okay, so during the construction of a building. BIM is not new, okay, so building information modeling historically has been used for 3-dimensional deliveries, okay, so but today is utilized, okay, so in a completely different environment. Okay, so we have the 4D models, basically incorporating, in this case, constructability, the 5D models that incorporates, okay, so optimization of schedules and everything else, and so on. So again, okay, so you will see a lot of changes in the delivery of construction projects. Next slide. Another item, okay, so that basically will change, okay, so as far as delivery of construction project is rebalancing the supply chains. We're looking for resiliency. Things, globalization, okay, so basically was a good thing, but on the other hand, okay, has paralyzed us the last 2.5 years. So they're basically, okay, so the big contractors are looking, okay, so to secure critical materials, building inventory. So thereby you're going to see, okay, so things changing. Bringing on the table, okay, so an old concept, and the old concept is vertical integration. Let's go to the next slide. So you're going to see more vertical integration, okay, so basically being incorporated, okay, so in the business of construction. The industry players have already started that. How it's going to play, okay, so again, okay, so with a lot of competing projects as far as the federal intent, okay, so in order basically to have public works and everything else, okay, so being again restarted, okay, so again there's going to be a lot of competitions for, okay, so 2 primary resources, okay, so labor as well as materials. So that's something, okay, so that we have to plan, that's something that we have to accommodate. Next slide. Again, okay, so I'm not going to spend more time, okay, so investments in technology, okay, so nothing new there, okay, so but, okay, so it's going to be escalated, okay, so they're completely different level. So at this point, okay, so I'm going to, even though there are a couple more slides, okay, so let's go to the, again, okay, so, oh, this is an important topic, okay, so increase in offsite construction. You're going to see more, okay, so what we call, okay, so prefabrication. We already started. As a matter of fact, my organization has positioned ourselves, okay, so in order to pre-approve all kinds of prefabrication methods, components and systems, so that way we can accommodate the new wave. So this is essentially, I don't want to call it, I guess, the way of the future, but it is the way of the future. So it will create, okay, so the delivery of a construction project, okay, so again more robust, okay, so again time, okay, so is money, okay, so it's an old cliche, but okay, so it will be brought to a different level. Next slide. So I just incorporate this slide so you can see, I guess, again, from ASIO, I guess, so some of the stats, I guess, so building information modeling is number 1, prefabrication is number 2, and so on. So I will basically give the floor at this point in time, but what is important to remember is flexibility and agility are essential components, I guess, of resilience. And we need to basically start thinking that direction in order to basically develop and construct the facility of the future that, number one, can accommodate, okay, so future needs, and number two, can accommodate any escalations with regards, okay, so to diseases that they will spread, okay, so quite often, okay, so because the way that we live. Thank you very much, okay, so for your attention. I will yield the floor, okay, so to our next speaker, okay, so, and again, I guess, you know, if you have questions, we'll have a small session, okay, so, but you can always email me on this email, and I'll be happy, okay, to respond to all the questions that you have. Thank you.
Great, Chris, and thank you so much for a fantastic presentation, especially from your professional opinion on what you've been dealing with in the field. Now we're going to turn to our next speaker, Vic, who's going to talk about what he's currently seeing and doing on site. Vic, thrilled to have you a part of our panel today.
Thanks, Mike. Appreciate it. So one of the things we want to focus on a little bit today is we've learned a lot from Chris, a wealth of information on the actual mechanical nature of healing and how we handle the facilities. And today I want to talk a little bit about the actual people and how we interact with the people that are part of the facilities. So go ahead and go to the next slide. And what we're trying to call is the 5 areas that need healing post-pandemic. And we broke it into 5 quick, simple issues between communication, finances, facilities, partnerships, and trust. So these are areas that in COVID took a beating, and they need to be brought back to a form that works best for healing for our patients. And the other part of it is just try to figure out a new normal for those areas. Next slide, please. So as design professionals that we work within the hospital systems and with the providers, we found that in-person communication has been lost. Now, it's not to say communication has become bad. It's just there's certain things that you get with in-person communication that you don't when someone pushes the easy button of a Teams meeting. Being in a room with somebody, having an interaction with somebody, you learn so much more about what the real problems are as opposed to hiding behind a one-sentence blip on a Teams meeting. And so we found that when we do that, we had a chance to learn a little bit more about problems that exist as opposed to if someone's on a Teams meeting. As far as leadership goes, we've always found out that within the COVID world, you had certain people that had a larger voice, a leadership voice. And that leadership voice is changed now that we've a little bit post-COVID. So we need to be very cognizant of that. Who's on first, who has opportunities to say the things that are important and recognize that, and be sure we work as a team to continue to heal the leadership as it transitions to a post-COVID world. And the last thing is licensing authorities. This has been a difficult one because trying to reinvent this, we did a whole lot of work with licensing authorities because they had to all leave their offices because they're all community government based. And so learning how to communicate with them, sometimes it was easy and very easy sometimes, and sometimes it was harder. And so learning how to better communicate with them is something that's critical to pushing forward post-COVID. Next slide. As far as finances go, staffing has been a critical part of this. When COVID came, a lot of people left the workforce. A lot of people left the facilities management's office. A lot of people left healthcare providers. Nursing is a very good example of this. And when that happened, you had a whole lot of people go to the agencies. My daughter's an ICU nurse, and the actual exodus of nurses out of the workforce to become agency nurses has made it very difficult. The care hasn't diminished, just they're all coming from a different location. Same thing has happened with some of the facilities departments. We've had facility department people that have retired and moved on, and it's created a void in the workforce. And then when we start talking about existing infrastructure, the things that we found with existing infrastructure is that as things have moved for these agency sources, sometimes it's hard to track them. I mean, if I have a facility manager who once was working directly for me, but now I'm outsourced it to another source, sometimes those finances are hard to track. And so we've been seeing a little bit of a struggle with some of our clients and how they're dealing with that. And finally, the supply chain. Chris poked on this a little bit, and I'm going to say this is a huge problem right now. I think everyone that's on this call probably understands that. Supply chain, we have a national rehabilitation hospital client who we have now completely redesigned all of their facilities to move from bar joist to red iron because of the limitation of getting bar joist. So everybody in the industry is having to make significant changes, whether it's bar joist, whether it's foam insulation for roofs. There's a significant amount of loss in the supply chain items that we're all going to make a huge course correction. Next, please. As far as facilities go, as far as certification goes, we have done much more self-certification we've had in the past, just because of everyone was so busy with COVID and how they had to handle the emergency nature of those facilities. And so we call it self-certification fallout, because we know that there's a knowledge base that we as design professionals have, that when we get involved, as this thing comes post-COVID, there's certain things in that we wish we would have had a little bit more communication with the licensing authorities to be sure, one, that we're accommodating what it is they need to have, and that we have a better understanding of what the rules and regulations are moving forward. So there's gonna be a little bit of time in here. We know that we're going to kind of have to relearn this process again. As far as reassessment of uses, Chris mentioned this as well. As you switched over to floors that used to be med-surg, you've moved them over to ICU. We have tele units that became ICU. The question is, are they going back to those purposes? Are they going back to med-surg? All those projects that were on hold that, hey, we were going to do a med-surg floor, maybe we shouldn't do med-surg floor, maybe we should do a tele floor that can be convertible to an ICU. Those are the kind of questions that, you know, continue to come up. And the fact that Chris's research does a lot of help for us to support how we can better communicate with the end users how that can work. And then priorities, the same thing. It's all about patient care. Too often with the dollars that have been available, it's been hard to reassess the dollars to the appropriate net needs. If you're trying to talk about building a new floor, it's obviously way more expensive to build an ICU floor than it is to do a med-surg floor or even outpatient clinic services. But the problem is that a lot of the monies don't exist right now because the dearth of outpatient procedures such as surgeries and CAFs and things like that could generate revenue were put on hold. And so the finances now are focused completely on something else. And so the dollars sometimes don't exist. Next slide. Partnerships is what we have when we talk about the healing of post-COVID. This is a big one. The community is a huge partnership that we need to continue to develop. I know sometimes in facilities, we're all we're talking about is how we make the machine run. But the reality of it is the community lives in the facility, and reminding people and our professionals in our office and our consultants, the fact that, you know, how you touch the community and how the community reacts to all our facilities. We have to heal that. I mean, it's the stories that are out there of parents that are passing away because their kids can't be with them. You have to make the facilities more open, and the actual the perception of the facility needs to be that it is a place of healing, both not just for the patients that are in it, but for the entire community. Our consultants sometimes have gotten neglected a little bit because while they may have been a critical part of the process before, they become neglected. So we need to figure out a way to bring them back into the fold and make them feel like they're a part of the entire team. Too often, somebody that was a critical vendor in the past is no longer a critical vendor. And now you may have critical vendors that are absolutely vital today that in the future may not be as critical, but we need to be sure we hear their voices as we push forward to be sure that our entire team, both end users, administration, facilities, design team, community, are all have equal voices and have the appropriate voices moving forward. Next slide, please. And the final one is trust. This is one that we've worked so hard pre-COVID to get everyone to understand what everyone's role is and that everyone's role was important. And when COVID came, it became very difficult to continue to generate that kind of interaction and synergies that we know we're all pulling the wrong direction. And so whenever we have conversations internally and whenever we're with our partners, we always say the most important thing you can do is let people know that you can be trusted and that you have their best interests in mind. And that has to go throughout the entire industry, both from facilities to design professionals and all the way through the community. And that's what I have today. I'm glad opportunity to share this with you. I appreciate it. And thanks, Mike.
Absolutely, Vic, and I greatly appreciate you joining us today. Another great presentation, lots of good content there. So Vic, thanks for joining us today. And now we're going to head over to Lance Woolf, and he is going to guide us through the Joint Commission surveyor's perspective of all of these design changes. So Lance, we greatly appreciate you joining us today.
Great, Mike. Thanks for the introduction, and we'll go ahead and get started then. So we'll go ahead and start with the next slide, please. But basically what we're going to do is we're going to go over a surveyor's perspective in regards to you having an active construction project or prior to the construction project on aspects that your surveyor is going to ask for. Surveyors now, and this is also post-COVID, is going to be, they're going to be more intrusive, more involved with construction projects just because of multiple areas that they identified during the survey process when COVID was occurring and with the future building design changes that are occurring as well, as both Chris and Vic have talked about. So let's talk about the two main things that your surveyor is going to focus on, and this is not a surprise to many people, but one of the areas that they're going to focus on during your document review is they're going to look at your PIC rates. So they're going to look at your pre-construction risk assessment, and they're going to look at that during the documentation, and they're going to evaluate your ILSM measures as well. And we'll talk about the ILSM measures here in a little bit in a couple slides down the road here. But the most common finding during this time when they're looking at your PICRA is absence of evaluating the areas for vibration. So meaning when you're doing your construction project, you're actually evaluating your area to make sure you don't have vibrations going up the columns. So for example, they're not hearing the construction that's occurring on the fourth floor when you're doing construction down the basement when you're chipping out concrete. So that's going to be one of the areas that they are going to be focusing on. And if you do have that issue, they're going to want to know what you're trying to do to mitigate that. Are you changing the time? Are you changing the equipment that you're going to use? Are you saw cutting more than jackhammering? So that's what they're going to be mainly looking for. Also, the second part is going to be your ICRA. And this is, again, the main thing is they're going to make sure that you work with your infection control during the process. This is going to be more of a discussion on, did you get your infection control involved? Did they have any design changes? And what have you done to make sure that you're continuing to keep them involved during the project to make sure that you're mitigating any issues, any contamination issues during the project as well. Next slide, please. So let's talk about the active construction site. So the surveyors are going to go into the construction site now, and they're going to evaluate the life safety within the area. And what they're going to do is they're going to evaluate what life safety is, what is in place, and make sure that the correct notifications in case of an active fire are there. So if you're using a temporary fire alarm system, what specifically does that system do? How do you have notifications? If you're doing a case of right now where your sprinkler system's out, are you doing a fire watch, over 10 hours? If it's been out for over 10 hours, are you doing your fire watch? So that's mainly going to be the discussions that they're looking for is in regards to the life safety. If you do have temporary systems in place, or if you're just have an active construction site, they're going to want to know what you're doing in regards to additional fire drills. And what the ILSM says is quarterly. My recommendation is do more than that. So you as an organization, as a director, or as the lead overseeing the construction project, you want to make sure that you evaluate on how many fire drills that you feel are needed for your organization. But the minimum is quarterly. Also, they're going to check to make sure that there's negative pressure. And for many of us that got surveyed in the past, mainly what would happen with your surveyor when they show up on site, they'd look at your permits, make sure your ICRA was current, make sure your PICRA was current, and then they just check to make sure there was negative area. They kind of poke their head in, just evaluate, do a quick scan, and then they'd be gone. But now they're going to actually go in and walk through the site, so be prepared for that. Another area that I'm going to be focusing on is, are your tanks properly secured for whatever you're using? If you're using it for cutting, for hot pit, for hot work permits, that is one of the common findings that they're finding is they find the chains off all the tanks. They were still sitting on the transport rack, but the chains were hanging. Another thing is your fire extinguishers current. This is, in this case here, this would be whether your contractor actually has brought on fire extinguishers. The facility director was unaware of it. It was just sitting on the ground. Surveyor went over, looked at it, and it hadn't been checked monthly. And it was also, out of it needed to have its annual check as well. And then the last part is who's doing the safety checks. And the discussion on this one is going to be determining the level of skill. So in regards to, as a facility director, when you come in and you start working with the contractors, you're going to want to determine who is doing your safety checks daily. It could be the contractor, could be the facilities director, could be a hospital designee, could be somebody else that the contractor designates. But you want to make sure that you have that discussion to determine the level of skill, because that's exactly the discussion that your surveyor is going to have. It can't be a case where you just have somebody walk in and that's first day on the site and you're like, hey, here's a clipboard, do the safety checks. You want to make sure that people have been trained and are educated on what they're specifically looking for. Next slide, please. So let's talk about the ILSMs. As we know with the ILSMs, this is what you're going to do if you do have areas that are affected, and you're going to go through this list and decide which ILSMs am I going to use. You're going to identify them, and then you're going to show your mitigation strategies. So as with the number one, it could be a fire department notification. If your sprinkler system's down more than 10 hours, or if your notification system's down, for 4 hours on a 24-hour period, you're going to want to make sure you're doing your fire department notification. So you're going to want to go through this list. So it could be a case, then you're onto a fire watch. So you're establishing a fire watch. So if you have only those two things, those are going to be the only two ILSMs you're going to use, is 1 and 2. If your exits aren't affected, then you're not going to do ILSM 3, but you're going to evaluate it on your PICRA and when you're doing your project. And this is going to be also on your daily checks as well, is going to be your exits. So, with the third one, if you do have exits that are being affected, make sure that you're educating staff in the other areas as well, or the areas that are going to be affected. Signals and alarms, make sure that your temporary equipment and detection systems are in place when the fire alarm system is impaired. And some people go, hey, we do a fire watch. We have security sit there 24 hours a day. So it's not every time you're going to have a temporary fire alarm system, but that's what you're using your PICRA, and that's why you're utilizing their ILSMs, to this point, to be able to mitigate any to come up with any mitigation and identify any strategies. Also look at your firefighting equipment. I talked about that with the fire extinguishers. Construction barriers, the main thing that you're going to be wanting to do there is you're going to want to make sure they're all sealed up. This is also going to be under daily checks. You're also going to want to make sure that they're fireproof and fire resistant. And your surveyor is going to ask those questions. Surveillance, you're going to want to boost your surveillance of the buildings and equipment. And you're going to have a special focus on the construction areas and with your storage and evacuation and in the field offices, even on the outside. If something is tied to the hospital, remember that is surveyable. Next slide, please. Your survey is going to ask questions about debris removal. How are you taking that debris out? And what are you doing to lower the combustible? Are you covering it? Are you covering it with fire resistant material? And are you following the same path? That's going to be an important question, because if you're going different directions all throughout the hospital at the time, that's where you're going to have a problem with your infection control. So you want to make sure that you're going in and out the same way every time, so you're able to control those areas. And then you're also minimizing the debris removal in regards to contamination in other areas, just by following that exact route. Firefighting equipment training, one additional training staff. Make sure you're utilizing your staff, that they're trained on the firefighting equipment. You're just not saying, hey, here, just go grab a fire extinguisher. Fire drills, like I said, you're going to want to do at least one fire drill per shift per quarter. My recommendation is do more than that. Number 12, this is a big one, and this is going to be the most common one, is going to be education. So you're going to want to provide education, promote awareness of building deficiencies throughout the areas that are going to be affected. And then last is going to be your fire safety features. So you want to make sure you train staff to compensate for any type of structural or compartmental fire life safety features that are being compromised during that. If you have things that are related to ILSM, you want to make sure that you identify them on your ILSM document and how you mitigated that. Even so, you might have something that's related to these, but it's not listed in the 13, but go ahead and identify them. Next slide, please. Okay, so let's talk about mitigation strategies. We're going to go through these real quick so we can get to some questions here. You want to provide detailed contractors packet. You want to make sure your contractors know what they're going to be expected, during the time that they're there. And then also too, you want to make sure that your expectations are clearly identified, specifically in regards to life safety. And if you're in your Joint Commission survey window or your accreditation survey window, you're going to want to make sure your contractors are on top of all of that. Also, you ensure your daily checks, like we talked about, are being properly done by somebody that's educated, and make sure that you want to spot audit. And that's essential, because you can't put, you'd like to put full trust into your contractors at times, but things get changed, things get missed. So you want to make sure that you're still spot auditing your daily checks. You want to provide training to the contractor staff prior to the projects, and make sure that if you have a contractor that's coming in that's normally doing business and not hospital, make sure that you sit down with their staff and explain the differences between a hospital environment and a business environment. The focus is not just solely OSHA. It's you have many other facets that you have to that have to be looked upon during the construction project. So if you have a new contractor, really work with them, and to the point where when you do the bidding process, provide the contractors with a pre-test that they have to fill out, and they have to return that test, because that helps you evaluate what their skill level is in hospitals. And then last, ensure that any new staff that are coming out of the construction site are aware of the required standards. And this can be done in many different ways. Packets are handed out, make sure the contractors handed out the packets. And then also it could be to the point where they actually sit down, and I've seen them go to your YouTube channel and go through life safety aspects, specifically in regards to hospitals. Next slide, please. Okay, well, that's all I have. We're going to move on to questions here, I believe, Mike. And
We are. And Lance, hey, greatly appreciate you joining us today and being part of the webinar. Great information. So we are going to go to the Q&A. So on the bottom right-hand side of your screen, you see a little Q&A button. If you have a question, just hit that button and throw it in there, and we'll work with our panel to get it done. It'll take us just a minute to get those compiled, and we will be back right after this.
Hi, everyone. This is Grady with Soleran. I just wanted to pop in and say thanks so much for attending today's webinar, and I wanted to briefly introduce you to Soleran and ICM. Soleran has been developing software solutions since 2004. We've dedicated ourselves to developing an intuitive set of solutions specifically for healthcare facilities. We've also developed the market's only true ICM platform. ICM stands for Integrated Compliance Management. So what is integrated compliance management? Well, ICMs are generally comprised of multiple solutions designed to work seamlessly together within one platform. There's literally hundreds of systems and processes across multiple departments used to manage healthcare facilities. ICM is simply taking all of those solutions across all departments and putting them into one integrated platform. Having all your data in one place allows the system to automate many of your daily tasks, gaining better visibility, trending, and analytics. It actually does work for you. Soleran's ICM consists of 6 individual suites that include work orders, rounding, permitting, vendor management, project management, and security management. Each ICM suite consists of 4 to 8 different applications that can be used individually, but you'll see the most benefit when it's used as part of the entire suite. Of course, ICM's unique advantage is using multiple suites across the entire platform. Bringing this information together in one place across all departments gives you better visibility than what you've ever been able to achieve before across the entire hospital or even across the entire healthcare system. When your data starts working together across an ICM platform, you'll be able to visualize your data using new tools like the Compliance Survey Dashboard or the fully integrated Life Safety Drawing Manager. I know I went through this really quick and at a really high level, but we just wanted to introduce you to Soleran, ICM, and the tools that will ensure you're ready for your next survey. If you'd like to learn more, contact us at soleran.com anytime. We really appreciate you attending the webinar today and hope it's informative and useful for you to manage your facility better. Mike, back to you.
That is great. And we have all the questions compiled, and we have a few questions and they're really well thought out. And Chris, I think I'll hear with the first one, but Vic and Lance, if you have anything you want to add to it, definitely chime in. But Chris, when we think about the new changes and recommendations and building designs, what are the types of feedback that you're receiving from hospital facilities that are currently in the design process?
Well, if you take a look at hospital design and construction, the process as a whole, it's treated historically to be a linear process. Well, maybe that was years ago, but today we live in a dynamic world. So things are changing extremely fast. As I said earlier, new designs, new methodologies, new techniques are coming forward, which basically building standards are behind. So as designs move forward, so the designers, the hospitals, they need an answer today. And the reason is that hospitals basically have to deal with multiple licensing agencies. So we don't want to build a building that won't be licensed tomorrow. because somebody else deals with the licensing requirements with regards to the operational requirements. So Vic actually mentioned the key word right there, partnerships. By statute, basically, we are a regulatory agency. We cannot operate under these premises. We got to operate under the premises of a partner. We got to be there during the initial steps that the designer is starting to consider the physical environment and the hospital so that we can provide all the answers. So the feedback that we're getting is we need help. So thereby, are you going to be there, okay, so for us, okay, so to basically run all those questions through you? So I found myself, okay, so literally being the broker, the moderator, okay, so call it whatever you want to call it, okay, so the partnership builder, okay, so among the various other regulatory agencies, with the intent so that everything is addressed during design. So that way, okay, so when construction is finished and when we issue the certificate of occupancy, now I have an operation facility, and we don't fall in a situation of where the licensing agency goes forward and says, you've got to change this, you've got to change that. Changes are extremely costly, time, money, and so on. So the facilities are asking all kinds of questions. We've seen it all. So thereby it behooves us, okay, so our organization to be there with a designer, especially when there's a question, okay, so how do I deal with higher acuity spaces that they can basically move from one use to another use and so on, okay, so those are the types of questions that we're getting, okay, so but the fundamental issue, or as far as I said earlier, how can I deal with a BMS system? So my job is, okay, so to literally step ahead, even though it's not in the building code, okay, find solutions through alternate means and methods so that I can make construction happen so the people of the state of California can enjoy the best possible healthcare.
Got it.
Sorry for the long-winded response. Okay, so
No, it's great. No, it's a great response. Vic or Lance, did you have anything to add to that?
No, he covered it pretty well.
Yeah.
And he's right. It's all about getting together as a team, as partners to figure it out. You can't, the day of being adversarial on this stuff is gone. It should have been done a long time before, and COVID's forced it to happen.
exactly.
Right. Yeah, it takes us to the second. So Vic, I'll kick this one over to you. So you mentioned staffing issues within hospital facilities, which we have all seen and experienced. Are you having those same problems in the private sector within your company that is causing delays for you? And if you are, what are you doing to help reduce that problem?
So I go on a daily basis saying we need help. And I think that's throughout the entire community, throughout the entire country. We all need that help. But part of the way we're alleviating that a little bit is that we're doing more cross training. We had experts that were healthcare experts that we're now taking that expertise and we're dividing it amongst more multiple people, doing more training, teaching people more, or those very specific skills that come with healthcare architecture. And we're using the same kind of opportunities, having lunch and things like that to share that knowledge base, because that's the best way we can at this point in time, because it is difficult to find people. We are finding them. It's very difficult. But the industry, as far as healthcare goes, that particular segment is specialized enough. You'd think it would be the difficult, but it's difficult to find people that do that. So we're doing is we're finding people on a very slow basis, but we're trying to cross train and really educate people to know what's going on.
Yeah, and that's really insightful, Vic, and thanks for that. And the last question, and we're running a little bit short on time, but I want to make sure it gets in. So Lance, from a surveyor's perspective, in the past, mainly, surveyors just check the permits and verify negative pressure. Why is there a recent increase of surveying in this area?
Well, and Chris has already talked about this as well. The accrediting agencies have got together and they realized that, because of COVID, there's going to be multiple design changes that are going to be occurring within facilities. So it's like I said, it's going to be a dynamic process. It's evolving, it's changing every day. So with the accrediting agencies, with all those changes, they've decided that they need to have more of not as much as an intrusive, but as more of a partnership, to walk into these areas and have that discussion on what's occurring, what are they doing to build in redundancy, and just start those discussions there, to help with, future pandemics or just future expansion. As we know, many hospitals found out, specifically with COVID, that value engineering wasn't actually the best thing for pandemic. So they were struggling, many were struggling to try to get additional air. Some couldn't get air, as Chris, talked about as well. So that's the main thing, is they're going to go in, they're going to start the discussion and see, what's the future direction, and what's the strategy of the organization on that specific project.
Got it. And so first of all, that ends today's topic. And let me just thank Lance, Chris, and Vic. Guys, thank you for your time. I know it's valuable, but the value you provided for the webinar is just outstanding. Great information, and we've all benefited greatly from it. So thank you all for joining today. So we have 2 more spring webinars coming up. So be sure to register for on April 28th. One is on the importance of environment of care tours. We have some great speakers from Thomas Jefferson University Hospital and Women's Brigham and Young. We also have another webinar on May 12th, and this one's about emergency and water management standards. We're excited about our speakers from Children's Health in Dallas and CIHQ, so be sure to sign up for those as well. Registration's open. These things do tend to fill up very quickly. So just a couple reminders. First of all, an email with a link to our future webinars is going to be going out, so you'll see that in your inbox. And we encourage you to share that with your colleagues and let them know about your experience on today's webinar. What I love about what we do is just getting community together and just learning from each other and sharing those best practices. So if you go to Soleran.com and you click on resources, that's at the top right-hand side of the page. There you'll find information on the Facility Compliance Think Tank, the Q&A, and the opportunity there to watch some of our other webinar recording that we've done in the past for some great tips. In closing, we want to encourage you to use the Facility Compliance Think Tank Q&A. We always have folks available to answer your questions. And the group is on LinkedIn as well. So you can go on to LinkedIn and look for the Facility Compliance Think Tank and get additional questions answered by our industry experts there as well. So if you're interested in the information about any of our products presented during the video or at the beginning of the presentation, just reach out to us by scanning the QR code and we'd be happy to connect and chat. That concludes today's webinar. Soleran and our speakers would like to thank you for joining us, and we definitely look forward to seeing you guys next time. Thank you.